Thank you so much for the introduction, and it's an honor to be invited to speak at the ISPN this year. I was specifically asked to discuss the pediatric cervical spine clearance and a product that we were able to create from the cervical spine clearance working group. I'll try to keep things interesting, although I know it will pale in comparison to the entertainment value from the current elections going on in the United States. So back in 2017, Marty Herman, who's a pediatric orthopedic surgeon out of St. Christopher's in Philadelphia, he wanted to get a sense for how pediatric cervical spine was cleared after trauma around the United States. So he sent out an electronic survey to members of the pediatric orthopedic membership in North America, asking specific questions about the services that were used to clear the cervical spine, imaging modalities used, and some other things. He got responses from about 25 institutions. The majority of those were level 1 trauma centers. And as you might expect, there was tremendous variability in the responses that you received. At some hospitals, general surgery and trauma services were clearing the cervical spine. Others, it was orthopedic surgery or neurosurgery or some type of rotating schedule. There was also variability in the types of imaging used. Some primarily use CT scans, some use radiographs, or a combination of both. At the end of the day, less than 50% of pediatric trauma hospitals in the United States had any type of written standardized protocol to clear the cervical spine in children. Now, if you look at the current literature out there, this variability holds true. The NS-CNS Joint Section put out a fairly recent comprehensive guidelines review, and there was no standard protocol there. There are more than 100 articles out there regarding pediatric cervical spine clearance with dozens of algorithms. But the problem is that most of these are institution specific. The availability of certain subspecialty services may not be applicable everywhere. It's largely determined based on the familiarity of different physicians in different disciplines at those hospitals. And very few of the protocols are based on any type of high-level data. So the goal of this working group was to try to employ the Delphi method to achieve consensus among a multi-institution and a multidisciplinary group of experts. And then with these consensus statements, try to develop an algorithm that people might be willing to implement across different hospitals. So this is the group Marty put together. This group of 25 physicians from 20 different institutions. It was heavily weighted toward orthopedic surgeons, as you see there, but it did include at least a couple stakeholders from all the important, some of the most important disciplines like pediatric emergency medicine, which at least in the United States probably is the biggest single group clearing the cervical spine, pediatric neurosurgeons, trauma surgeons, radiologists, and so forth. So for those of you who are less familiar, the Delphi method was a process developed by the Rand Corporation back in the 1960s, actually to try to figure out how many atomic bombs were necessary for the United States to build to try to minimize the chances of further war with the Soviet Union. But the process involves getting a group of experts together, using a series of carefully designed questions, including some feedback and information, and then trying to develop a consensus of opinion with a convergence of opinion. So this method has been used successfully in pediatric spine surgery a few times. Mike Vitale at Columbia put together a group of people to develop consensus statements to minimize the incidence of surgical site infection after primarily neuromuscular scoliosis. Similar group of people worked to develop a checklist to respond to intraoperative neuromonitoring changes during spinal deformity surgery. And then we brought this more recently to pediatric neurosurgery to develop some best practice guidelines to try to reduce the incidence of surgical site infection after complex tethered spinal cord surgery. So with this process, we started out with a couple surveys with several questions. This was followed by a face-to-face meeting in 2017, and then some post-meeting questions as well. As you can imagine, an extensive literature review was conducted during this process. statements were created, yes and no agreements. And as usual, consensus was defined as greater than 80% agreement, and then an algorithm was able to be generated from the consensus. So the first thing we had to do was to agree on the purpose and goals. So we decided and agreed that the purpose of a pediatric cervical spine clearance protocol was to identify significant cervical spine injuries in children who have sustained blunt trauma. Our goals were to identify all significant injuries, minimize radiation exposure to the child, permit the removal of a collar or any type of brace as soon as necessary as possible, and efficiently and effectively utilize healthcare resources. So here's the protocol in one fell swoop, just to kind of show it to you in one image, and then we'll break it down into the different pathways that the children can enter the pathways. So unlike most other cervical spine clearance protocols, where entry into the protocol is determined based on age or mechanism of injury, this protocol, entry into the pathway, is based on initial or admitting Glasgow Coma scale, with pathway 1 being the children that are essentially normal mental status, pathway 2 being children who are in coma, and then pathway 3 is that in-between group. So starting with pathway 1, which is the vast majority of children that probably don't even get to see any of us as pediatric neurosurgeons, are those kids that come in with an essentially normal GCS. And the goal here was to emphasize the physical examination and the history, and try to clinically clear these children without the need for any type of radiographic studies. So if you look at this portion of the pathway, again, these kids come in, and these are all physical examination history questions that all of us are familiar with based on, nexus criteria. And essentially, if these things are normal, then you can clear, and the kids are moving their neck around without having much difficulty or pain or something, then you can clear these kids clinically. But sometimes you'll have some of these kids that still have some neck pain, or they're complaining about something, and that's when we decided to move towards conventional plain x-rays, not a CT scan. And at least a lateral view is probably the most important one, and I'll address that in a minute. And if those are normal, then then we move to an area where we need to clear the spine, the possible ligamentous injury. Now, in the adult world, there's a lot of evidence to suggest that just a plain CT scan in an adult, if it's normal, is sufficient to clear the cervical spine. But as we know in children, we're not there yet, because there are multiple studies, large studies in the past, which demonstrate that in children, ligamentous injury of the cervical spine is more common than fracture. So we need to clear these kids' ligamentous injury as well. So options for that include, either moving their neck around because their symptoms resolve, moving towards flexion extension cervical spine x-rays to ensure there's no ligamentous injury, or you can leave them in a call or send them home and bring them back to your office in a couple of weeks to reevaluate after their muscle spasm and other symptoms have resolved. These asterisks, we tried to put a little bit more details and guidance in terms of what we felt based on the literature was, high risk injuries such as diving or axial load or motor vehicle collisions, or what other types of distracting injuries were important, such as if it's life-threatening or required inpatient hospitalization. So this is a study back in 2009 looking at whether it's necessary to include other radiographic views like an open mouth view and AP views, or whether a lateral cervical spine view was sufficient in terms of radiographic imaging. And this looked at the sensitivity, specificity, positive and negative predictive values of lateral cervical spine x-rays in comparison to multiple radiographic view x-rays, with the CT scan as the gold standard. And what you can see here is that it didn't make any difference if you obtained other radiographic views of the cervical spine. So really a lateral cervical spine x-ray, certainly in the vast majority of situations, is sufficient. So let's move on to pathway 2. This involves children with a GCS less than 8, so they're presenting in coma. And these are the kids where you can't do a physical exam to clear their neck, and you don't feel that their mental status, or it's unlikely it's going to improve within the next few days to be able to do so. So based on data from the pediatric Emergency Clinical Research Network System, or the PCARN, the chances for a cervical spine injury in these kids who present in coma is so much dramatically higher that these are the children where we felt it's justified to move straight to a CT scan. And if the CT scan is normal and you can leave in a collar and you feel that they are going to improve within 3 or 4 days, then you can just wait for that, repeat their examination, and you might be able to clear the cervical spine. If it doesn't look like that's going to be likely, that's where MRI gets involved to be able to assess the ligaments to make sure there's no type of ligamentous injury. Now, there's equipoise in literature regarding whether the utility of MRI in general. Doug Brockmeyer put out a pilot study comparing the different modalities and suggested that MRI is not really necessary and flexion extensions CT scans might be better. But there are also, there's ample data in literature also to suggest the value of MRI. And the real issue with MRI is its tendency to overcall ligamentous injury and show findings that may not be clinically significant. So moving on to pathway 3, this is probably the most difficult group. We're that middle ground with the patients presenting with GCS from 9 to 13. And these are kids that you just can't clinically clear them because of altered mental status or pain or other findings. And the plan for these kids, the idea would be to put them in a collar, just get radiographs, especially if you think their exam's going to improve within 12 to 24 hours. And then if it looks like it's not going that way, then go ahead and move to the CT scan. So just in a visual format, the kids come in here. And again, if it looks like their mental status is quickly improving, you can just get a plain radiograph and then examine them later and clear the cervical spine. And if it doesn't look like that, then they're going to move towards a CT scan because their mental status is way off and they're probably going to need that. And again, if there are any abnormalities in any of these imaging findings or something like that, then it gets kicked up to a spine consult, or basically a referral to a provider that has more experience in cervical spine management. So, there are a lot of limitations to a study like this. A Delphi study is really nice. It brings people together and can get consensus of opinion, but is far from scientific evidence. There was bias among the panel as primarily orthopedic surgeons, academic institutions only, and only in the United States. It only addressed recommendations for blunt trauma patients. It didn't address issues with children with like a child abuse situation where the risk for injury is much higher, or children who are developmentally disabled. We don't know if this is applicable in non-pediatric institutions, and importantly for this audience, is this applicable globally? The good things about something like this, though, is that there are plenty of data out there to demonstrate that algorithms in medicine improve clinical care. There are some unique aspects in terms of the entry based on GCS and so forth. And the feeling among the group was that this could serve as a starting point, and that if groups are willing to implement this protocol at individual hospitals, then the real work begins about whether after implementation of the protocol, this can really make a change in the practice of medicine. Questions like, is the workflow reasonable and efficient? Does it reduce the amount of time to remove the collar? Can we reduce imaging utilization? And I'm pleased to say that the answer to that is yes. Marty Herman just published a paper showing that comparing two groups, one group before the protocol and one group afterwards, there's a more than 50% reduction in the use of CT scan and the use of x-rays and so forth. And most importantly, is the protocol safe? We need to make sure that there is not a high missed injury rate, so we can keep our children safe and try to prevent problems with spine injuries, especially if our children that we see engage in certain behaviors such as this. So in case any of your children are fighting Jet Li on the flaming rooftop, then hopefully we'll keep them safe. So thank you for your attention. I'm happy to try to address any questions if anyone has any.
Thank you very much, Richard. We're on time. There are no questions actually from the on the Q&A. so far. Maybe we can have more questions as they come along. And Francisco, you want to get on to the next speaker first?
I do have a question for Richard.
Okay.
So Richard, my question is, what's the next step? I mean, are you already considering or collecting data prospectively to see the reliability of the algorithm in terms of outcome correlation with what you expect?
Yeah, it's a great question. So that's being done at individual hospitals right now. We haven't put it together to do it in a multi-institutional fashion yet, because every hospital has its unique issues, as you know. So we wanted to get a little bit of data, at least from individual hospitals, to see if there was agreement at different centers before trying to do something multi-institutional wise.
Thank you.
Okay, some of the questions are coming in now. There's a question from Shlomi. Have you seen cases of miscaught injuries that led to catastrophe?
So we have not seen any of those yet with implementation of this protocol. And to Shalomi's point, the difficulty, if you run the numbers, the incidence of significant spinal injury is so low that to demonstrate that one protocol is safer than another protocol is probably going to require tens of thousands of patients. So it's a difficult thing to prove statistically, but we have not seen any missed injuries, and especially in centers where it's the only pediatric trauma center for 4 or 5 states around. I think the chances of capturing those would probably be pretty good.
So there is another question about the place of MRI, but I think you only mentioned it in the type 2 or the group 2 that you do MRIs, right? Yeah.
Yes, we do group 2 in the kids who have mental status is poor and in coma and so forth. We use MRI to rule out the ligamentous injury if we can't do it, with flexion extension X-rays or other means.
Right. I think there's a question on whether CT is mandatory, and I think you mentioned that especially in the group 1, you probably don't do CT at all, more for group 2 and possibly group 3.
Yes.
And there's another question saying that, a comment saying reporting of plain X-rays in peds can be challenging, especially of ours. There are many variabilities. How can we base our steps on that?
Yeah, so good question. So the good thing is that probably, statistically, the vast majority of kids that come in don't even need X-rays because the majority of them can be clinically cleared based on their exam and absence of findings. In those kids that do need imaging studies, I think it's very true that trying to get an open mouth view and oblique views and even AP views are often very difficult. I think you can pretty reliably get a lateral cervical spine X-ray in almost all children. And I think that the studies show that that's the most important one, and there's really not a lot of value in the other ones. So I think it is important screening stop because the majority of those situations those kids will not end up needing a CT scan, and you can avoid a lot of radiation exposure.
So there are 2 more questions basically on MRI. I think one of them said, do your recommendations address the timing of MRI in comatose patients? That is, does the time from injury affect the sensitivity or specificity of MRI?
Yeah, it's a great question. So there are mixed data on that in literature. The official AANS CNS guidelines recommend to try to get the MRI within 48 hours because you're looking for edema, and the thought is that edema could go down after that time period. From my personal experience, and I think experience of a lot of other people, sometimes it's just not, kids are too unstable and you can't get the MRI within 48 hours. And then we just usually recommend to do it as soon as possible.